and we're going to talk about sort of what actually prosthetic valves. Mainly, I will focus on bioprosthetic valves, but we really want to see what sort of bioprosthetic, what the components are, and how that has actually some implication on the clinical outcome. I think that sort of is important because, certainly in our hospital, we always ask now for the make and model. I think it'd be quite nice sometimes for people who scan, the physiologists and the doctors, to know actually what does it mean, because there are lots of valves out there, but they're quite common, frequent valves used. And I think it's quite important to understand what are these valves, how does that maybe have an impact on clinical sort of outcome for the patient, looking after them. Are there stentless, stents, pericardial valves, whatever. So I'll briefly talk about that. The benefits and disadvantages of bioprosthetic and mechanical valves, which is a very sort of hot topic because people are more and more using bioprosthetic valves. Is that a good thing, or should we stick with mechanical valves? Understanding the difference between structural valve degeneration and non-structural valve degeneration, and also touch upon prosthesis patient mismatch, and some echo multimodality imaging assessment tips, and then some cases. And the cases are the most interactive ones, okay? So these are sort of the valves we deal with. Some of them are sort of historic. I think there are very few Starr-Edwards valves, which is this ball and cage ones. So the one in red are the ones we commonly see. Most mechanical valves are bi-leaflet. There's hardly any, certainly over the past 20 years or even longer, there wouldn't have been any single in Western healthcare systems. We would all be bi-leaflet valves. And then we have these bioprosthetic valves here. Somebody will get a different prize if they know what the difference tissue is between this one and this here, but somebody can put that in the chat. Doesn't anybody know what tissue D is and what tissue E is? And then we have the TAVI valves, which we know are two kinds of valves. Either they're balloon expandable, which is the Edwards valve, which is the commonest used, the Edwards valve, or the self-expandable valve, which is traditionally the Medtronic valve, but obviously it's not company specific. Okay, so mechanical valves by leaflet, and then the stented valves, and the TAVI valve. But I'll be talking about not talking about that much about the TAVI valve. So talking about the bioprosthetic valves, and broadly speaking, you will either have stented valves, okay, with stents, or you have stentless valves. Where you don't have any stents. The big advantage of a stentless valve is that you have more space and they generally have a bigger orifice area. The stentless valve, you can see there's a lot of material around there for the surgeon to put in before you can actually have a valve which can let the blood out, meaning the orifice area is actually smaller. Not many people use the stentless valves, and the congenital people use stentless valves more. Our surgeons don't tend to. Sometimes in endocarditis cases they do. And then, of course, you also have the superannular valves, when people have a small annulus, that you can put them sort of above the annulus, with the theory that you get a better orifice area. And then also, importantly, apart from knowing that they're stentless valves, superannular valves, you can have some valves where the valve leaflets are mounted externally, and that's important. So you can appreciate the difference between the bottom right corner and, for instance, the perimount magna, which is inside. And you can see the theory is that if it's mounted externally, that you have a bigger orifice area. So these are sort of the common valves, of course, we use are the perimount, or the surgeons use, sorry, not me, perimount magna valve. Perimount magna ease valve, that's the one here. The trifecta valve was commonly used, the mitral flow, and obviously they got a little bit out of favor. They're the common valves that we use. Okay, so just a brief idea: stented, stentless, superannular, externally mounted. Okay, what are the different components? The different components: you have a stent, then you have the different stent posts and the ring, and then you have the actual leaflets in there. This is the Carpentier-Edwards perimount. Inside. This is one of the commonly used valve, and probably the valve that has the best durability data. This here is the Hancock valve, which is also another one of the top two bioprosthetic valves with the best durability data. Very similar build, okay, but it doesn't but it has this the stent doesn't have these posts. This is porcine tissue, and this is bovine pericardium, okay. So one of the ones in the first picture was bovine pericardium, and the slightly thicker leaflets are the porcine valves. Okay, and here you have a mitral flow, and you can see here, as I said earlier, this is also a bioprosthetic valve, but it has leaflets mounted outside. Okay, but if you sort of understand the different kinds of valves that might come and might be on the echo request, or you might see on letters, it's not bad to know the different components. And I'll tell you why that's sort of important. Now, the important thing here, so this is a paramount valve, as you can see here, with the stent post and the ring and the internally mounted leaflets. You can appreciate that they're different diameters, and I think that's an important sort of message that you might hear about a 21 millimeter or 23 millimeter. What does that refer to? Okay, you can see here you have the internal diameter here is of course is a lot smaller than the external diameter or the sewing ring diameter, and of course that is the important one to know is when you have to either retreat them or actually how big the actual valve is. And I think that's really, really important. Okay, and they're the different components here: the stent post, the valve leaflets, the suture cuff. Okay, but the sort of key message is that the internal diameter is sort of the important one, really. And if you here look at the valve from a different aspect here, again, this is the internal diameter B, which is the actual important diameter to understand how much actually of all the valve tissue is available for the exit of the blood. You can see that that's a lot smaller than the external diameter or even the outer ring diameter. Okay, so that's why the important thing here, it's of particular importance to note that the manufacturer's label valve size does not correspond to the inner base or to the inner diameter here. Okay, so if you have a 21 millimeter mitral flow or 21 millimeter paramount, that doesn't mean that there's 21 millimeter of orifice available for the patient, and that's really important. It is significantly smaller. So why is it smaller? So this here, this is it's just a really very simple drawing, just to explain. So this one here is a bovine pericardial prosthesis, okay, with the pericardium outside the ring. So that's like the trifecta, the mitral flow. So the internal diameter there is the full orifice here. Okay, so there's no reduction in the valve internal diameter. Now here, this one here is a bovine pericardial prosthesis where the leaflets are inside the ring, and you will lose a little bit of internal diameter. So this one would be typically paramount magna. Okay, and that's typically reduced by 1 millimeter. Okay, because the leaflets have to be in there. This one is a porcine one, which is typically the Hancock valve, and there you actually lose 2 to 4 millimeters ID. So therefore, if you, for instance, have a porcine valve like the Hancock, the actual internal diameter is smaller than if you have a bovine valve, but even smaller than one that's externally mounted. Okay, so that's sort of important. So if you have a 21 millimeter mitral flow, you probably can expect to have a slightly bigger orifice than a 21 millimeter paramount magna, which is bovine pericardium internally mounted, and that will be even bigger than a Hancock valve, which is a porcine valve. So knowing a little bit of what kind of valve is important. Now, do you have to remember all of this? Probably not, but just to understand that the differences and that the figures and the companies really haven't got together to actually provide a really meaningful number is really important. And of course, there are these fancy apps now these days that you can check all that. So just down here, the stentless valves are probably has the biggest orifice area, biggest internal diameter, more than the externally mounted, the bovine internally and the porcine internally mounted. Okay, as I just mentioned. Okay. So this is one of the apps you can have. This is the Valve PPM app, which I'm sure all of you have on your phone, which is a fantastic app for entertainment. No, it's not. But it's a good one that certainly all the interventionists use, and actually also the surgeons use, because it provides a lot of information. They have all the valves on there and tell you exactly what the detail is. And here I just put some data in, okay, for the Paramount Magna Ease. So Paramount Magna is, again, most people are familiar with that name. And I put a 21 millimeter in, okay? And you can see here what the expected parameters are. And I think it's sort of important to realize what the orifice area, the effective orifice area for a 21 millimeter valve is 1.4. Now, that's plus or minus 0.4, okay? So you will have some valves that will only have an orifice area of 1. if you have a 21 millimeter valve. So that's quite interesting, isn't it? So you know, if you think you're sending a patient with severe aortic stenosis that is classified as an orifice area of less than 1.9, and you might have a major operation, open heart surgery, takes 6 months to recover, and then you're told that congratulations, you have a new valve, and then if you ask, well, how much bigger is it than my old one, and they say, well, it's 0.1 squared centimeters more than your old one, you might be a little bit disappointed, but that is the reality. Okay, that a small valve will give you a small orifice area. Amrit, if I drop off or anything, you text me or anything. You can all hear me, can you?
Yeah, we can.
Yeah, good. Okay, and so the other thing you can see here, the true ID is 19, and you can, as we said before, it's a bovine pericardium here, and it loses 1 millimeter of true diameter, so it's the true ID is 19 millimeters. Okay, so the stent ID is 20. If you didn't have any leaflets in, that's 20, but you have the leaflet stuck inside, so you lose 1 millimeter. And as I said before, for the porcine valve, you lose a bit more. Okay, so that's the 21 millimeter, and you can see the 21, figure 21 doesn't correspond to actually any number here. Okay, so that's just to give you an idea. Now this is the Onyx mechanical valve, which is again a common mechanical valve, probably one of the best in class. And that's the 21 millimeter. And you can see here, and that's why I sort of showed it to you, the orifice area for a bileaflet mechanical valve, and you can see it down there, is 1.7. So that's significantly better for the same size type valve than a tissue valve. So it provides a better flow profile and better effective orifice area. And that's sort of a key message, that a mechanical valve generally gives you better effective orifice area, the newer ones, than an appropriate sized a tissue valve. Okay, the Onyx valve particularly is good because they don't have this sort of tilted angle, but the leaflets actually open, the two discs actually open at a 90 degrees angle. Okay, which is important. So 21 millimeter that's the summary of 19 millimeters. Equivalent size has a better orifice area, and generally mechanical valves have a better EOA than equivalent size bioprosthetic valve. And that's an important thing, okay? Especially when you're sort of trying to plan sort of what size they have and what, if you want to avoid this, you know, the whole term prosthesis patient mismatch, i.e. too small a valve for their body. Sometimes you should consider a mechanical valve. The app is also great because you can actually check you can put all the data in, weight and height and the valve, and you can check which one might cause prosthesis patient mismatch. Okay, so here are common valves that we use, and just again to give you an idea, okay, for a sort of pretty average sort of, you know, for West Yorkshire, probably almost even skinny male. And the body surface area, I can't remember what the body surface area was, certainly was above 2. But you can see here, if you put into a person like that a 21 millimeter Paramount Magna, which is the commonest valve, this is the effective orifice area, but this is the index valve area. And we know that the index valve area is the indicative or the marker of a prosthesis patient mismatch or as too small a valve for their body. And you can see any valve that is below 23 really gives you a patient prosthesis mismatch. So again, a clear sort of message is, if you ever scan people with valves smaller than 23 millimeters, you almost, before you scan the person, will expect slightly higher gradients, unless the patient is small. But in a bigger person, you'd be surprised not to find higher gradients. Okay, so all valves that are smaller than 23 millimeters usually are at risk of a prosthesis patient mismatch, and are also in the literature called small valves. Okay, again, the surgeon won't always agree with you, but that is fact. How do the surgeons size the valve? The surgeon, once they've opened the heart, they put this little device in, this sort of sizer, and then they see what they can fit in. Because if that sort of plunger, it looks a bit like a plunger, doesn't it? If it gets stuck or can't get it in, then that's too big. And then they have to make it smaller, and then I think they have a little gauge on the thing, and that will tell you what kind of size they can put in. And obviously, what we're trying to do together with the surgical team is we're trying to sort of prevent that. We don't want to sort of measure it in theater. We will have an idea how big the annulus and LVOT diameter is, what size valve is in. Therefore, in any echo report, it's really crucial that the LVOT and the annulus diameter is in the echo report and not corrected for height or arm length or size of your head or your feet. it just the absolute measurements. Okay, so because we're increasingly getting these measurements that are all corrected for all sorts of things, and I actually personally I don't have a clue what they mean. So the absolute diameters are the important thing, and that's also important because to identify patients potentially who are at risk of a prosthesis patient mismatch, and to tell the surgeon you might need to do something about that. And I'll tell you about how you can prevent prosthesis patient mismatch later. Okay, choice of mechanical versus bioprosthetic valve, that's always a big discussion these days with TAVI. These days, there's more and more people who don't want a mechanical valve. What's the general decision making? Generally speaking, a 60 to 65 is the cutoff, where you say you probably shouldn't have a mechanical valve, you should have a bioprosthetic valve. Why is that? Because bioprosthetic valves do have less durability. If you live long enough, they will fail eventually. People, obviously women in childbearing age, because mechanical valves need warfarin, and the risk of that is so much for the patient and also for the fetus. If patient has risk factors for structural valve degeneration, you have to consider, should you put a bioprosthetic valve in or mechanical valve, and if there's anticoagulation contraindication, and the things on the otherwise on the other side for the mechanical valves, it's quite obvious, sort of the opposite. And it does also, as I mentioned earlier, have a better hemodynamic performance. So biological valves are increasing, and it's interesting countrywide down south. They're significantly increasing in younger patients between 50 and 65. Is that a good thing? Because people might say, well, but of course it's a good thing. You don't need warfarin. You have a tissue valve, and you can always treat it later on. But is that really correct? Because in medicine, we're full of ideas that sound like a good idea. A lot of people then go ahead and do it, and then it turns out not necessarily to be quite correct. Because the idea is that bioprosthetic valves these days are much more durable, 15, 20 years. You can always put a TAVI valve in there. And of course, you really worry about the bleeding risk mechanical valves, and you don't need anticoagulation, and you can live a life. You can do bungee jumping, contact sport, everything, because you don't need anticoagulation. But then there was a Swedish registry data, which is interesting, and that's sort of again, so this is the paramount prosthesis, which I'm sure you all recognize, internally mounted bovine pericardium, and a mechanical bileaflet valve. Although this isn't an onyx valve, because we know the onyx valve has a 90 degrees opening angle. But what they looked at is the age group between 50 and 59, and they showed that people with mechanical valves, they have a significant survival benefit over the ones with a tissue valve. So if you put bioprosthetic valves into a too younger age group, there's a trend that these patients, that affects their mortality. Okay, so mechanical valves overall had better survival, and the risk of reoperation was decreased, because we know that mostly they only need one procedure. And the risk of bleeding was, however, marginally increased. So that is always the trade-off. However, you do live longer. Okay, so I think that's an important sort of thing to realize. And why is that? Well, it makes sense, because bioprosthetic valves, when they fail, and we'll see some cases, they don't just gradually fail. They often can fail quite acutely. Equally, TAVI is another procedure, isn't always straightforward, and often hasn't been planned, or isn't always planned appropriately to put the right valve in. Not every tissue valve is suitable for a TAVI and valve procedure. So therefore, one has to be cautious about putting too many bioprosthetic valves in younger patients. And we always talk about lifetime management of patients with valve disease. And lifetime management does actually tell you that maybe you should consider a mechanical valve, but it's the patient's choice. And then about bleeding risk, because that's always the key argument that is used. Now, the bleeding risk does increase. So this is bleeding. This is the thromboembolic complication. And we do know that bleeding risk increases significantly the higher the INR. We talk about it all the time at MDTs, because we often have sort of valves that seem to have inappropriate INR targets too high. And you can see why it's important. So the bleeding risk after sort of 2.5, 3 increases exponentially. And of course, the Onyx valve, we know it has an INR target around here, just below 2, with aspirin, and their bleeding risk is really quite small, isn't it? So I think the bleeding risk is there, but actually it's probably slightly overrated, and with the newer mechanical valves, probably isn't as much. So I'm not sort of a big seller now of the mechanical valves, because it is really a patient choice, and you do need to have warfarin, but equally one just has to look also at the evidence. Okay. Now, bioprosthetic valve, this is just a graph. When you have a bioprosthetic valve in age 20, your probability of structural valve generation is 90% almost. So if you have a bioprosthetic valve at young age, you definitely will have valve degeneration. So therefore, the saying is, the longer you have, if you have a valve and you live long enough, it will degenerate with the bioprosthetic valve. But if you're older, so your sort of chances actually only so 15% probably if you're 65 of having degeneration, and therefore there's a 75% chance that by the age of 75, 75 that it won't have degenerated. Okay, so what are we talking about bioprosthetic valve dysfunction? I think one has to differentiate these sort of terms. And I think that's probably not a bad way to look at it. You talk about structural valve degeneration. What does that mean? That is any degeneration that intrinsically affects the actual valve leaflets. Okay, opposed to, and that's wear and tear. Okay, just like as a picture down below. You have non-structural valve degeneration where the actual valve is intact, but it's something not intrinsic to the valve. Typical examples are paraprosthetic leak, the malposition, patient prosthesis mismatch, all those things. Okay, they are non-structural valve degeneration. And then, of course, we have thrombosis, and we'll see some cases, and endocarditis. So that's all what can happen really with a bioprosthetic valve, and actually also with a mechanical valve. Okay, sort of those four sort of complications. They're the things we look for also on imaging, on echo, or on multimodality imaging when things go wrong, and that's just to bear in mind. It's important, and it is important to differentiate structural and non-structural valve degeneration. Because one of them is wear and tear and is sort of the nature of the actual valve, and you can blame sort of the actual valve make. But the non-structural valve deterioration, you might have a perfectly well-placed valve in there, but it actually has nothing to do with the actual make. It might have something to do with you put too small a valve in, surgical technique, etc. So it is important to differentiate. So the normal sequence clinically is that you have bioprosthetic valve dysfunction, then you eventually have hemodynamic changes, and eventually you have clinical consequences. Patient has LV dysfunction, symptoms, and eventually either dies or needs a valve replacement, has complete bioprosthetic valve failure. Okay, and there are also endpoints that are used for in studies. Okay, so what is structural valve degeneration? It's a bit of a busy slide, but I think it's sort of important to know what it is and the definition. It really is that you have thickening of the leaflet, usually that is degeneration, okay? But the important thing is that you have an increase in the mean gradient from the baseline echo, okay? And also a reduction in flow independent parameters, which is a DVI or reduction in EOA. I haven't put the figures in for the EOA because I just don't trust that there really is such good inter-observer variability that you can do that. So therefore the DVI is, I think, more reliable, but that's the important thing. So if we look at a valve and look at the MDT, you try to find the baseline echo, and has the mean gradient gone up? But that is not enough, because the patient might run up the stairs and the mean gradient 2 years later will be higher. That doesn't mean, and the patient is tachycardic, breathless. That doesn't mean that the patient has valve degeneration, because when they're tachycardic or hyperdynamic state, the DVI won't have changed. So therefore, you need two things. You need the mean gradient increase and also reduction in the flow independent parameter, which, as I said, I find DVI is the best one to go for because it's the most reproducible. In the mitral valve, you talk about an increase of baseline from 3 and severe of 10. And the severity, again, is a little bit arbitrary, but I suppose it's still something to use. So a severe valve degeneration, the increase of mean gradient is 20, and the decrease of DVI is 0.2 or more than 40%. So that's, of course, when the valve is stenotic. And usually it's mostly the stenotic, but sometimes you can also have a situation that they get aortic regurgitation. And again, you compare it with the baseline scan. Is there more aortic regurgitation, intravalvular aortic regurgitation than baseline? And then you look at the different grade, and then you can grade it. So hopefully that is clear. The definition of structural valve degeneration is the increase in both the mean gradient from baseline, but also the flow independent parameters. What are the risk factors? So patients who have bioprosthetic valve, as I showed you on the other graph, who are young, and I think it's partly also because they just use the valve more and do more, and they're more active. So there's more wear and tear. That's a risk factor. Diabetes, kidney disease, and actually, importantly, if you actually have implanted too small a valve, patient prosthesis mismatch. Okay, we should call it prosthesis-patient mismatch rather than patient-prosthesis mismatch, and poor blood pressure control. So they're the risk factors of that the valve might degenerate a little bit quicker. Okay, I'm just keen that I don't run over too long. Prosthesis-patient mismatch, again, this is differentiated by BMI, and I think the thing what you probably should remember is an indexed valve area of around 0.65 is classified as significant patient prosthesis mismatch. And what is it? It is the valve is working absolutely fine, but you've just put in too small a valve, or the surgeon has put in too small a valve, or could only put a too small a valve in for their body surface area or for the cardiac output. And for an MVR, it's less than 1.2. Is it bad to have too small a valve long term? Yes, it is. It causes mortality increase, especially if the mismatch is severe. And we know it causes symptoms, remodeling, left ventricular hypertrophy. It is even worse when people have pre-existing LV dysfunction. There's some good figures out there. So you can imagine it is not good to have too small a valve for you long term, because effectively you've replaced severe native aortic stenosis with sort of severe aortic stenosis caused by too small a valve. And how do we prevent that happening? That's the important thing, because it really is depressing and frustrating when you get a patient and you do the echo and the gradient is almost the same as it was pre-operative, and you almost think, I have to actually have the operation. And what do you do? The surgeon can do a root enlargement, and they can do that. They can do sort of a fairly basic one by increasing up the size. They can increase up the size of the prosthesis by 1, and they can do a slightly more complicated one. Supraannular valve, theoretically, with a slightly better flow profile. Stentless valves, as I said. TAVI valves generally, because there's just less material and the true internal diameter is bigger, is generally better. These days, also the surgeons have these sutureless valves that you might have heard of that are better. And of course, you can have a mechanical valve. So they're, broadly speaking, and I won't go into detail, ways of preventing too smaller valves and this condition called prosthesis-patient mismatch, okay, which is an index valve area of sort of more than 0.65. What do we need from the echo? This is a busy slide, and I think most people know what you need. There's nothing new here. The only thing I would sort of appeal to people that you do the VTI, both in the aortic valve and the outflow tract. And if you have all that data, then one can, one can usually try to figure out what's going on. The effective orifice area, as I said, I'm not a big fan of, because I just find it difficult to be reproducible, especially getting the correct LV outflow tract diameter. It's difficult enough in native valve disease, but then if you have a stent poking into the ventricle, I think it gets quite difficult. Okay. If you insist on measuring the outflow tract, they do seem to be different. We can talk about that, where you measure the diameter in a stent. There's some studies, certainly this was a study protocol, you sort of zoom into it and you do it for sort of outer edge to outer edge. I tend to sort of do it just bang onto the stent. Some people use inner edge, but I find that the inner edge often is absolutely tiny. So be interesting to see maybe later on the comments where people tend to measure the outflow tract in a now this is obviously what we can recognize as a TAVI valve. This is it looks like an evolute valve. Where you measure it. I tend to measure it either outer edge to outer edge or just bang onto the stent, in the middle of the stent, actually. Okay, so this is the minimal data set. We know that. What do you try to determine on the echocardiogram? You try to determine if it's obstructive or non-obstructive. That's really the key thing. Obstructive is a structural valve degeneration, or you have thrombus, pannus, endocarditis. Excuse me. Non-obstructive, you can have prosthesis-patient mismatch or regurgitation or hyperdynamic flow state, and then some weird and wonderful things down there. But that's the key thing. If you have a high gradient, that's always the key question. If you have a high gradient on your echo, what does it mean? Is it that the valve is working fine, but it's just too small a valve? Or is it that the valve is working fine and there's the hyperdynamic state for whatever reason? Or is it actually truly dysfunctional, either due to wear and tear or due to thrombus or endocarditis? That's always the key question. Or it's working absolutely fine and it's not stenosed and its size, it's a good size, and there's actually the gradient is caused because there's additional volume, i.e. due to regurgitation. Now, this is some sort of echo. There are a lot of different echo flow charts, and each guideline always changes. So how would you potentially do it? And as I said, I must say, I don't use this very commonly. Some people do. If you have a high gradient across the aortic valve, what you do, you can measure the thing about you can measure the acceleration time and the ratio of acceleration time to ejection time, and you can see what the ejection time is. Acceleration time is the time it takes to the peak acceleration, and the ejection time is the whole Doppler envelope. So you can do that. If the acceleration time is more than 100, it tends to be obstructive. The more sensitive marker or more specific marker seems to be the ratio of acceleration time to acceleration time. And then you look to see what the valve area is, and if the valve area is small and there's more normal motion, it's patient prosthesis mismatch. If it's actually bigger than that, then it's hyperdynamic state. If it's obstructive, you tend to use other imaging modality to see what the actual cause of it is. Is it pannus, thrombus, endocarditis, whatever. Okay, so I won't hover too much on this here. And the slides I think will be provided. I can send over the slides if people want the slides. You can ask Amrit for the slides if you want. I'll send Amrit the PDF file of this here. Okay, so I won't hover too long because I already am slightly over the time. For the mitral valve is similar. What I do think is quite helpful is the mitral valve BTI and LVOT BTI ratio. That's not a bad one. Again, it doesn't completely tease it all out, but it's not a bad one. If it's more than 0.22, it's abnormal. And it either means it's obstructive or there's regurgitation. The pressure half time is not a bad trend. The pressure half time is not used to calculate the mitral valve area. That's important. It's not validated in prosthetic valves. But if it's short, it's usually not obstructive, and it's usually significant mitral regurgitation. And if you have that, you should sort of go hunting for the regurgitation jet and maybe ask for another imaging thing. But that's what you sort of should do. And again, this is just a rough guide that you can look at. We won't have enough time to go through this in detail, but again, you can see that on the slides. What do? I think it's really important to look at gradients, look at the baseline postoperative echo. So any prosthetic valve assessment you do, you have to make the time. I know everybody's busy, but you have to make time to compare it with the baseline echo, because otherwise it's very difficult to come to a conclusion. Now, sometimes people don't have a baseline echo. These days, our surgeons, partly because of bullying from my side, are much better at requesting the echoes, and we have baseline echoes on most surgical valves. Why they wouldn't do it beforehand, I never understood. If you put some prosthetic material in, don't you want to check if it's working okay? But I'm not a surgeon. They're different species. Check how big a valve is, and you will know from this presentation that aortic valves in the aortic valve position that are smaller than 23 millimeters, they probably will be quite small. Tissue valves around 25 usually are quite small. And look at an app to see what is the predicted valve area, and do you expect ppm or not? Look at the valve leaflets, and are they moving normally or not? Because if you have a high gradient and the valve leaflets are normal and moving normally, it isn't going to be obstruction. It's going to be probably ppm, or it might be regurgitation. Mechanical valve fluoroscopy is extremely useful, okay? But it's really important that they don't do a quick fluoroscopy. They have to get a right angle to see both leaflets. Otherwise, and we've had that case ourselves, you sort of think one is not moving, but you're just not seeing them, and that's why you falsely interpret it. So it's really important that not an interventionist with an attention span of 2 seconds does it, but you really go and find the right angle on fluoroscopy. So generally speaking, you can have mostly 4 outcomes. You have a small valve, it's often can be ppm. Look at the predicted effective orifice area. Look at the post-operative echo. Were the gradients high post-operatively, and have they changed significantly? If they were high post-operatively, it's likely to be ppm. And if the leaflet motions, and you've proven that is normal, it's usually ppm. High flow, is there conditions of hyperdynamic heart? Is everything being are the leaflets working fine, or is there dialysis patient? Is there any reason? Look at that. Usually in a hyperdynamic heart, you can see it. The ejection fraction will be sort of 65, 70, 75%, and the velocities will be high everywhere. Is there an obstruction? Is there an indication of an increase in gradient? Is there from baseline? Again, compared to baseline, is there abnormal leaflet motion? Regurgitation, look at high gradients with a normal DVI, and scrutinize for the Doppler. But they're the sort of 4 scenarios, really. Okay. Might skip this here. because I want to get to the cases. So that's sort of a brief overview of prosthetic valves. Okay, I don't know if you found it interesting or not, or if it was too geeky prosthetic wise. I'm going to stop my sharing. How do I do that? There you go. Okay. I don't know. Amrit, do you want to press on with the cases? Unless, does anybody have a question at this stage? You can put it on the chat thing if you want to.
Okay, so I'll start with the cases in the meanwhile. So I'll just share my screen. Okay, so you can hopefully all see my presentation now. So my name's Amrit, and I'm one of the cardiology registrars at the LGI. And thank you all for joining us on this Wednesday evening. So this is interactive, all the cases. So make sure you have your smartphones ready. There will be voting for some questions. So this is a test question that I just wanted to make sure everyone's familiar with this website. So there is a QR code on the top, which you should be able to see. So if you were to scan that QR code with your phone, you should be able to vote for this question. So how useful have you found this session till now? These are your options. There's only one right answer really, but if you want to give it a go, I'll give you another few seconds. If there's any trouble, do put in the chat and we can try and solve it. But QR code, or you can go onto the website, which is over here, and you can vote that way as well. Or I think the other way to do it is via text, but I think that's a bit too complicated to do it that way. Okay, so we've got 20 replies in. If anyone's having any trouble, do put it on the chat and we can try and fix it. So let me just see the responses. So our responses, so this is a breakdown. Most have found it extremely useful. Some have changed their life for some, so good. So I think it's working for the majority of people. So we'll move on now to the cases. So the first case is a gentleman, we'll call him Mr. C, who is 42 years old. He was admitted with kind of acute on chronic breathlessness, accompanied with musculoskeletal left-sided and non-specific chest pain. His significant past medical history included a mechanical AVR back in 2006 for severe AR, and he had a 19 millimeter Sorin valve put in. Few years, almost 8 years after that, he then had a mechanical MVR for severe MR and had a 25 millimeter St. Jude's valve put in. Other thing of note was that he was type 2 diabetic. So he got admitted. These were his blood tests, which were pretty unremarkable. Troponin was marginally raised, but it was non-dynamic. ECG, there's nothing much to say, it was quite pretty unremarkable. So he had a transthoracic echocardiogram, and I hope you can all see this. The videos properly. It does take a bit of time to start playing properly. So this is I'll just go through all the images so you can have a proper look at it. So the parasternal long axis. This is just a view of the valves again with some color flow. So color compare. And this is a 5-chamber again with color compare. And a typical 3-chamber. He then went on to have a TOE. So this is our kind of first image for the kind of like an LVOT view. Move on. So this is again a color compare of the aortic valve. 3D of the aortic valve again. And it's a true view of 3D of the aortic valve. So these were the parameters that were measured on the echo. So the peak forward flow was raised 5.2, mean gradient of 63, peak of 107, and severe AR was reported as severe AR. So this is another question. So if you want to answer this, what is the most likely diagnosis? Is it prosthesis patient mismatch, infective endocarditis, prosthetic valve thrombus or pannus, structural valve degeneration, or is it something else, or none of the above? I'll give you a few minutes if you want to vote. So either scan the QR code, you can vote online, or you can text in as well. Okay, so we had 16 votes till now. Let's give it a few more seconds for some more people to vote, and then we can have a look at and see what people thought. Okay, so up to 19. So let's have a look at what you thought. Okay, so quite a split. Most people going for prosthetic valve thrombus, pannus, and quite an even split between the other three options. Okay, so
this is a mechanical valve, and mechanical valves, of course, don't have structural valve degeneration. They were mechanical valves, weren't they?
yes.
Yeah. So the mechanical valves don't have really structural valve degeneration. Structural valve degeneration is a term used for wear and tear of a bioprosthetic valve. Yeah.
So based on that, if you're sure of your diagnosis, or even if you're unsure, what would be the next investigation that you would like to do? So cardiac CT, do another TOE, cardiac MRI scan, fluoroscopy, or we're pretty sure of our diagnosis, don't need to do any more investigations. We have 17 responses. Give it a few more seconds for a few more responses. All the responses are anonymous, by the way, so please do answer. Okay, so these are this is our answer. So most people went for fluoroscopy, some cardiac CT, and a few went for TOE, and even had CMR. Right, so I guess what we did, we went with the majority of people. We did fluoroscopy next, and so this is a fluoroscopic images. So this is the first one. See the mitral valve. And we move on to the next one. So this is the aortic valve.
I think it highlights nicely how, depending on the view, that you can't always see the other valve, especially. So you really have to pay attention, because you can clearly see the valve there now, but it's really important to get the right angle.
Yeah. So this was the other view. This is the view of the aortic valve. Right. So I think most of you kind of had the diagnosis. So it was diagnosed as acute on chronic thrombotic partial occlusion of the AVR prosthesis, and he quite promptly went on to have surgery. This is the op note. There was fresh clot on the aortic prosthesis, along with some pannus underneath that. No evidence of infection, and some pannus was also visible on the mitral valve, not as significant as on the aortic valve. And this patient then had a 21 millimeter St. Jude mechanical bileaflet valve inserted. This is his post-op transthoracic. So I'll show you some pictures. I think the AR is pretty much gone now. And these were his parameters that we got. So pre-op, post-op was he was still an inpatient, and then post-op during a clinic follow-up in 3 months' time. See the AR had resolved, and his velocities and gradients had come down quite nicely, and DVI had also increased.
I think it's a nice case, and I think often with these cases, with the mechanical valves, when things go wrong, the question often is it pannus or is it thrombus? Now, we're not going into detail about that, and it often is quite difficult on imaging to determine the difference. I mean, sometimes you get clues in the clinic. So if the patient hasn't been compliant with their warfarin, then you obviously get a clue how long has the valve been in there for. And that often is the only one. Now, there's some theoretical things. You will see tables if you have sort of fresh mobile stuff, and one of the images did show some mobility, I think, or mobile echogenicity. That's more suspicious of a thrombus, and often also the pannus is a little bit more slowly progressive. And this guy, I think, presented fairly acutely. And interestingly, he intermittently went to pulmonary edema when the valve got completely stuck, and then it sort of loosened up again. So it was quite a scary moment, actually. So this was an interesting case where the fluoroscopy really was helpful to determine that there really was a problem there. Interestingly, if I put it into the valve PPM match, the 21 millimeter St. Jude's mechanical. So as I said before, a 21 millimeter in a bioprosthetic valve is actually quite small, but as we saw on the Onyx valve, 21 millimeter mechanical valve is probably not bad, and it gives you an EOA of 2 plus or minus 0.7. Peak gradient of 15, mean gradient of 8. So overall, not a bad valve, and actually his gradients there are okay, depending on his body surface area, obviously. So overall, that's a good result, but the patient was significantly ill.
We just had a question in the chat about why fluoroscopy was the better option here over a repeat TOE.
Well, I think he had a TOE. We sort of got diagnosis there, and I suppose sometimes the fluoroscopy is just to complete. Did we really need the fluoroscopy? It just really to absolutely confirm the diagnosis that there's a problem and almost get the surgical attention also. And the fluoroscopy is such a nice way of visualizing the mechanical valves. And it's so easily done. You know, it doesn't take long. They go down, and it really takes a few minutes. As I said, the caveat is it has to be done properly, because otherwise it's like any investigation. If it's not done properly, it potentially actually can be harmful because it sends you down the wrong path. So I think it was important. It's quick and easy and accessible. That's why TOE is an invasive test, and this guy was intermittently going into pulmonary edema. There was concern. The discussion was because he has a mechanical mitral valve in there, and I think his initial valve was 21 millimeter. Is that right? His initial valve. So the question, and he's a young chap, so there was the fear, what kind of size valve will we get in there? And there was a fear of creating prosthesis-patient mismatch. And again, that sort of was something to be considered. But this guy had pannus and a thrombus, and he may have initially had a too small a valve in. So yeah. Move to the next case.
Right, yeah, we'll move on to the next one. So second case is of a 68-year-old lady who had been diagnosed with severe AR back in 2016. Just thought there was a valve perforation, so it's thought likely secondary to previous endocarditis. Significant past medical history was she'd had a previous subarachnoid hemorrhage. So she was quite symptomatic, and she went on to have a bioprosthetic AVR using a solid 19mm valve in November 2016. Her post-op recovery was quite unremarkable. She was discharged home on the day 9 post-operatively. So this is her post-op baseline transthoracic echo after her AVR. Nice short axis view. And this was her baseline parameters after her valve was put in. So Vmax of 3.5 meters per second, peak of 49, mean of 29, a DVI of 0.35, no AR, and her LV function was normal, so above 55%. So again, this is a question. So I'm afraid you do have to scan the QR code for every question to be able to answer it. So I guess the question is, what would you do now for this lady now that she's being discharged? But she has these high gradients. Would you repeat echo in a few months? Would you do an urgent repeat TOE while she's in? Consider redo surgery, discharge her back to her GP. Now surgery's been done, or will you do something else? So I'll give you a little while to vote. So we've had 11 votes in already. Okay, so we've had 19 votes in, so let's look at the 20 now. So let's look at the answers. So most people would repeat echo in a few months. Some would do an urgent repeat TOE. So I think we went with the majority of people. We also thought we would repeat the echoes, follow her up in 3 months' time with a repeat echo. So she had her surgery in November. So she came back in 3 months' time and had a repeat echocardiogram. And this is a table comparing the two echoes. And this Doppler profile is from her new echo, so her 3-month post-operative echo. You can see that the velocities and pressure gradients remain roughly the same, no AR, LV function remains good. But at this time, she started complaining of some symptoms of shortness of breath. It was felt that she hadn't really engaged with post-operative cardiac rehab as much. So she was then sent back again for some more cardiac rehab and physiotherapy. So another question. So what is the most likely diagnosis based on what we've seen? So again, you have to scan the QR code and then answer. So the options are structural valve degeneration, prosthetic valve thrombosis, prosthesis patient mismatch, or endocarditis. Yes, we've had 19 answers in now. So let's have a look at what most people think. So, so 100% of people think that it was a case of prosthesis patient mismatch, which is what we thought as well. So she was followed up quite closely, 6 monthly to a yearly basis. So she had these are all her interval scans showing all the gradients. As you can see, her Vmax up to 2018 remained roughly the same, as did her pressure gradients, and her DVI hadn't changed much. There's no AR, LV function remained normal. And she did have shortness of breath in 2017. After going to through rehab and probably after her post-op recovery, she did improve, and her shortness of breath seemed to have subsided completely. She was then again followed up in 2019, had another echo, and symptomatically she felt quite well in herself. So nothing to get too worried about up to this point. She had another follow-up in 2020 and a further one in 2021. Now, on this follow-up, she was extremely symptomatic. She was complaining of a lot of shortness of breath, almost finding it debilitating. She had an echocardiogram, and again, the velocity and the gradients are shown here. So there was a bit of an increase in her velocity compared to 2018 or before, and in her gradients as well, with a drop in her DVI. Still no AR, and her LV function remained normal. So she went on to have a TOE because of the worsening symptoms, and these are some images from her transesophageal echo. So first one, color flow. The short axis of the aortic valve. (3D) of the aortic valve. So after looking at that echo, so there's another question: what would you do next? Now, keeping in mind that she is quite symptomatic now and finding it quite difficult. So would you follow her up in another 12 months or 6 months even, do a stress echo, CPEX, or would you do something else? So I'll give you a little bit of time to vote on this. Okay, so we've had about 17 votes in, so let's see what most people think. So, okay, so the majority, so 47% people think we would CPEX. Quite a few think that we do something else, and 17% would do a stress echocardiogram. It'd be interesting to see, maybe perhaps in the chat, what other investigations you could have considered, because there's no right or wrong answer. In this lady's case, we decided to do a CPEX. This is a CPEX report that came out, and of note, her exercise duration, she only managed 2 minutes and 8 seconds. She was very short of breath, but the physiologist here quite remarked that the patient hyperventilated from the start of the test, which is quite important, and then her predicted VO2 max was only 44%. Now, given her symptoms, her CPEX, and her TOE, she was then discussed in our valve MDT. We saw that the valve parameters remain largely stable, although there might have been a slight increase in her velocity, but this wasn't felt to be enough to explain her symptoms. Her CPEX was terminated early, and it was noted that she was hyperventilating right from the beginning. So she was referred to the respiratory clinic, from which she was referred for chest physio for some management of likely dysfunctional breathing. And in the MDT, there was just 3 options that were proposed if her symptoms did not improve, which were to think of a mechanical AVR, but this we'd have to keep in mind that she had had a previous subarachnoid hemorrhage. The other one was a valve-in-valve TAVI. However, this was felt to be unfavorable given the prosthesis patient mismatch, or whether she just went on to have a redo bioprosthetic AVR.
Just Amrit, just brief comment about that. Well, it's good that you can show that. I mean, as Islam said in the chat, I mean, there was concern because her Dopplers actually had now gone into the severe range. So we didn't discount that the aortic valve not causing the breathlessness. And I think it's also important to say that once you have a prosthesis patient mismatch, that isn't forever the explanation for a high gradient, because as we've determined before, people with prosthesis patient mismatch also at higher risk of structural valve degeneration, and they often actually need a lot less for the gradients to go up significantly. So it is always a tricky one, but one has to be careful not to say, oh, the gradients are high because of the small valve. If the gradients increase, if it indeed can be the valve, and in her case, clinically, and that's the thing with valve disease, you have to put the clinical stuff together, because not just look at the echo. And one of those echoes was a little bit of an odd one out. I would have probably looked at it. I think the TOE didn't necessarily suggest significant valve degeneration. I don't know. You show the next slide. That's the only comment I wanted to make.
Okay. So this is again just a table of her echo. So we reached up to 2021, and then she came back 2022, and then again in 2023, and her velocity had gone down slightly. Pressure gradient has also gone down. DVI had started to improve, and ejection fraction remained more than 55. But more importantly, her symptoms had almost all resolved. So shortness of breath had improved a lot. And looking back at the chest physio, the respiratory physio's note, they did think that she had an element of dysfunctional breathing. And after a bit of training, that also improved. Also, at this time, she retired from her job. She used to work as a nurse. And I think all of this kind of helped with her symptoms as well.
I mean, it's a good case, isn't it? Because other people might have intervened in 2019 saying, well, listen, that valve needs to come out. But it wasn't straightforward with her. And her, if you can look at the Doppler parameters, they're very similar to a baseline echo. So it is an interesting case. Some people might argue, well, you were brave to do that, and you could have gone wrong. But it is important. And again, just to remind people, if you have a high gradient across the aortic valve or any valve, it's usually one of four options. It's either a too small a valve. Look at the baseline echo. It could be an obstruction. Okay, that's usually an increase compared to the baseline echo, and the motion is different. The motion of the leaflets is incorrect, or everything's fine. The valve is big enough, and you can have regurgitation, or you can have a hyperdynamic heart. So one of those four, usually it is. And in her case, it was an interesting case. Because clinically, she was difficult to assess. She was always breathless. You can look at postoperative. She was breathless. She was always breathless. And it just was a quite interesting case. Now, maybe she had some thrombus on the valve and it went, and that's why the Dopplers got better. Or some of the echo parameters here weren't quite correct. Who knows? I mean, we did do a TOE, and I think if there's doubt, if there's question, you have symptoms, you have to do another test. I think some people suggest a stress echo. That is probably not a bad one either. In this case, we probably got it right, but as I said, other people might have argued differently. So now it is 2037, and I do appreciate that it's late, but Nick has two good cases. I completely understand if people want to drop off and go to bed or whatever, but there's some good cases that Nick has. So if you want to stay, I think that'd be great, because there's usually something to learn. Off you go, Nick.
Sorry, I was just muted for a second. Hope everyone can hear me okay. Thanks, Amit, for some good cases there. So as I say, appreciate it. It's late, so I'll try and whiz through these fairly quickly for everyone. So our first case is an 81-year-old man who had a background of a tissue AVR, which was a 23mm Edwards Perimount Magna for severe aortic stenosis back in June 2020. Of note, his post-op course was complicated by AF, which may become relevant later on. Normal LV function pre and post-operatively. So he's got a background of hypertension and also posterior circulation stroke. So of note, he's anticoagulated with rivaroxaban 20 milligrams and a host of other sort of range of medications. So this is his echo 3 months after surgery. So back in 2020, September. So I'll just show you some of these images. So not the best quality, but here we've got 4-chamber. Just shout out in the chat if you want to see any of the pictures again at any point. Here we've got some Dopplers of the LVOT and also CW through the aortic valve. So just to summarize, so 3 months post-op, normal LV function, normal wall thickness, AVR is well seated and functioning well. So he's seen in surgical clinic for his post-op review in March 2021. He's feeling much better. He's back to swimming half a mile twice a week. And he actually had an ambulatory ECG, which showed he'd gone back into sinus rhythm. So his rivaroxaban was stopped and the aspirin was restarted. So just to summarise the change, he then has another echo in February 2021, and we can see here that there's been quite a marked increase in the peak forward flow and also the mean pressure gradient. DVI was not calculated, and the LVOT forward flow has also increased. At that point, there was just a plan for a repeat echo 12 months down the line, so wasn't anything sort of urgently actioned at that point. So in May 2022, he's actually admitted with symptoms of epigastric pain to the LGI A&E, and he actually has a troponin elevation. So he's admitted for a period of telemetry, sort of query acute coronary syndrome, and his telemetry actually shows he's gone back into AF. So at that point, apixaban is started. He was previously on rivaroxaban at 5 milligrams BD, and he also has a beta blocker increased. So as part of his new AF workup, he has a repeat echo in July 2022. So this is a third echo. And actually the gradients have changed, they've gone down a bit. So his peak forward flow is reduced to 2.7. I'll just show you some of these measurements that were done. So just to summarize again across these three echoes, so actually we've got a bit of flipping around of the measurement. So the 2020 peak forward flow of 1.9, then increasing to 3.5, and then down to 2.7, similar with the mean gradients. And you can see the DVI has not changed dramatically between September 2020 and 2022. So actually in November 2023, he then returns for his fourth echo, which is as part of his follow-up, and he actually mentions to the physiologist that he's had to go to his GP because his exercise capacity has declined, and he was previously able to swim up to 3 miles, and this is now reduced to 8 lengths. He doesn't describe feeling particularly short of breath walking or experiencing any chest pain. So this is the repeat scan from November last year. This is looking in the aortic valve in the long axis view. So Doppler from the right sternal edge. So just to summarise the findings from the fourth echo here from November of last year. So now mild concentric LVH, LV function still normal. Again, difficult visualisation of the prosthetic valve, but suggestion of some thickening, and as you can see, significantly increased forward flow measurements. Again, just to summarise the changes. So you can see both peak forward flow, mean pressure gradient have increased significantly, and we've got quite a marked reduction in the DVI as well. So first question for this case, what do you think is the most likely diagnosis based on the measurements and the images that you've seen so far? Is this a pannus, patient prosthesis mismatch, valve thrombosis, or structural valve degeneration? I don't know. I can't see how many people have voted on my screen, but we've got some responses coming in.
Can you open it up? I can't see the QR code there.
Nick, can you click on the QR code again?
Oh, yeah.
Brilliant.
Sorry, I have to click on it to enlarge it on my screen. So I don't know how many people have voted there, but I've got. Okay, so we've got a bit of a range so far. So no one thinks it's patient or prosthesis patient mismatch, I should say. A few people think pannus, a bit more for thrombosis, and then most people saying structural valve degeneration. So because obviously the patient was symptomatic, the gradients have gone up significantly, so the sonographer alerted the valve service to this patient, and an urgent follow-up appointment was arranged, and a TOE was also requested based on that echo. So pictures up to Valve Clinic of a week or so later in November last year, and reaffirms that breathlessness has been increasing for the past 12 months. Exercise tolerance is now only 50 yards on the flat, no chest pain or syncope. And also interestingly mentions that his apixaban has been reduced to half dose because he's now over 80 as per his GP. On examination, some signs of aortic stenosis with an ejection systolic murmur and a soft second heart sound. Unfortunately, he didn't tolerate the TOE that was arranged for the same day. So you've got a patient who's increasingly symptomatic, gradients have gone up on repeated echo, unfortunately not able to tolerate a TOE. So what would your...
Just make it a little bit smaller again, Nick, so we can see. Yeah, there you go.
Sorry, so what would your next management step be in this patient? Would you go for fluoroscopy, go for a cardiac CT? Would you admit the patient urgently for a TAVI, or would you repeat echo in 3 months? So, bit of a mix again. Okay, so a few's going for fluoroscopy, the majority going for cardiac CT.
So just an explanation again, fluoroscopy is useful in mechanical valves, okay? This is a bioprosthetic valve, okay? So bioprosthetic leaflets are not radio opaque, you can't really see them. So fluoroscopy is not helpful in a bioprosthetic valve, that's an important thing. So mechanical valves, yes, but in bioprosthetic valves, no.
So the impression of the consultant who saw the patient in Valve Clinic was that the perimount valve is usually highly durable, and therefore that this was potentially going to be subclinical valve thrombosis and less likely to be structural valve degeneration. So the plan was to initiate the patient on warfarin with a target INR of 3 and to arrange a TAVI CT with a thrombosis protocol. So the suspicion in this case was of a valve thrombosis, and the plan was for a TAVI CT in the first instance in addition to the warfarin. However, unfortunately, patient rings the valve nurses not long after this appointment, saying he's now having orthopnea and PND. His exercise tolerance was reduced still further to 25 yards, and he's also getting dizzy on exertion. His most recent INR was not where we want it to be, so it was 2.0. So at that point, the patient was admitted for inpatient TAVI workup. Here you can see the CT that was arranged shortly after admission, and you might be able to appreciate the valve there in the middle and the thrombosis that you can see there quite nicely. Has a repeat echo again as an inpatient, which shows LV function is still maintained. However, his gradients have gone up still further, so peak forward flow now of 5.7, mean gradient of 71, and a DVI of 0.15. So at this point, what would you do? Patient's increasingly symptomatic, gradients are still going up. Would you plump for a redo AVR, a TAVI? Would you thrombolize the patient, or would you carry on with the warfarin and get the patient to the target INR of 3 to 4? Okay, so responses coming in. So I think most people are majority going for thrombolysis. Some people think redo AVR, no one for TAVI, no one for warfarin. So the patient underwent MDT discussion, and the impression was that there was no appetite for redo surgery, given the age of the patient and sort of comorbidity, etc. And TAVI was technically possible, but there was concerns about the risks given the presence of some semi-organized thrombus, which would be difficult to control during the procedure. So the consensus of the MDT was that the patient should have thrombolysis, and that if this doesn't work, that would then potentially reduce the risks during TAVI of any fresh thrombus being present. Sorry, this is a bit of a complicated slide, but this is just to highlight the protocol for patients with suspected prosthetic valve thrombosis. So you may be able to see at the top of the screen that we use transesophageal or TTE complemented with CT, which is what we did in this case. So if you've got an obstructive thrombus, it depends whether the patient's in cardiogenic shock, in which case you go for immediate surgery. If you have a patient with class 3 to 4 NYHA, you go for thrombolysis over a shorter period of 6 hours. In our case, the patient was felt to be NYHA class 2, so we went for a protocol of 25 milligrams TPA over 25 hours with a repeat echo every day, with the patient monitored on CCU. So that's what we did. So over the course of 4 days, this was the changes in the patient's peak forward flow. You can, if you think of a peak gradient was 5.7 on the 5th of December, you can see things improved and then sort of steadily fell over 4 days. So the patient underwent a repeat MDT on the 12th, and the impression was that there was no indication for TAVI as the gradients were reducing. So the thrombolysis was discontinued, and the patient was established on high-dose warfarin, aiming for an INR of between 3 and 3.5. And then the plan was for home once the INR was in range. Quick side note that the patient then, before discharge, developed a bacteremia. And so then there was a potential concern whether there was endocarditis was going on. So you had an FDG PET, which was negative, as you can see here, showing no activity on the valve. The patient was then discharged on Christmas Day last year and was seen in valve clinic not so long ago, and actually doing a lot better. Exercise tolerance has improved. He's established on the warfarin, INRs between 3 and 4 without any bleeding complications. So the plan is for further follow-up in the sonographer-led clinic in around 3 months' time. So that's the first case. I don't know if anyone got any questions.
Just to summarize briefly, and we will try to finish by 9 o'clock, but this case really was difficult, and you can see it isn't always easy on imaging to completely nail the diagnosis, because it was again a mixture of clinical stuff. This guy has had a paramount magna, and he also actually was on anticoagulation, but his gradient went up fairly quickly, and you do wonder, because his echo, I think a year before, also see very seen a jump on the gradient, and it could be valve degeneration, but it's just very unusual for a paramount magna to have that, and therefore there was a clinical suspicion there's something else causing the obstruction. We knew that it wasn't PPM, because the baseline echo showed absolutely no problem. He wasn't hyperdynamic, and there wasn't any regurgitation. So therefore, we did think it was obstructive, and therefore then to determine the etiology, you need more multimodality imaging. You can't just rely just on a transthoracic echo, and the thrombus actually is not well seen. And TOE, wasn't possible. That sometimes is quite difficult. Probably would have seen the thrombus, but the CT, 4D CT is actually very good in that. So in this case, it was first see, is it obstructive or not? Yes, it was. And I was nervous. I saw him in clinic, and I actually was thinking of admitting him, actually. And giving anticoagulation, but these people have little reserve, because if it doesn't work, then the gradient goes up, and as you could see, his gradient was 5.7. So it was a bit tricky. The valve sort of network worked. He was in contact with the valve nurses, and we then admitted him. And fortunately, we just didn't have the time for prolonged INR, for prolonged warfarin. It just takes too long sometimes. So we had to be more proactive. And he did have he was 80, and he had a long respiratory wean, and therefore surgery probably really wasn't the right thing to do. So it was a really interesting case. And there's a slow thrombolysis protocol that we use that we can show you the reference for. But it was a good case. Okay.
Okay, thanks. So again, we'll try and be quick with this second case. So 70-year-old female, so tissue AVR, which was a 21 millimeter mitral flow in 2014 for severe aortic stenosis, past medical history of note of type 2 diabetes and hypothyroidism. April 2021, telephone valve clinic, feeling well, no symptoms of concern, so has a routine echo, which I'll show you some images for here. So just to summarise, normal LV function, well-seated AVR with peak forward flow of 2.1, mean gradient of 9, so reported as well-seated and functioning well. Repeat echo a year later, April 2022, to look at now. And just to summarise the changes in the measurements again, so you can see there has been quite a significant increase in the peak forward flow. The mean gradient's also increased dramatically, and the DVI has fallen significantly as well. This is a third echo, February 2023. And actually you can see, so from the third follow-up echo in February of last year, again, further increase. So peak gradient, peak velocity, sorry, 4.2, mean gradient of 36, further drop in the DVI to 0.22. LV function is preserved and the patient has remained asymptomatic throughout the follow-up period so far. So we've got an asymptomatic patient. Based on the echo images and the measurements, what do you think the most likely diagnosis is here? Is it patient prosthesis mismatch, structural valve degeneration, pannus, or valve thrombosis? So majority plumping for structural valve degeneration, few for patient prosthesis mismatch and pannus. Shout out if there's anyone who's got any comments about that. Otherwise, we'll move on. So what would you do now? Would you repeat the echo in 3 months? Would you organise a TOE? Would you organise a cardiopulmonary exercise test? Would you refer the patient for a TAVI? So majority looks like going for TOE and a few going for repeat echo in 3 months. The plan from the clinic was for a cardiopulmonary exercise test to see if the patient was truly asymptomatic, and then after that for a follow-up in the valve clinic in 3 months' time, with a safety netting of contacting the valve nurses if any deterioration in the meantime. Unfortunately, patients unable to manage the CPX test has to be terminated because they can't use the treadmill or the bike effectively. So then has a telephone clinic appointment in July. At this point, is now mentioning that she's breathless, is housebound, not experiencing any chest pain or syncope. So she's, at this point, there's concern. So she's referred that there's some deterioration in the valve. So she's seen in the joint surgical and TAVI clinic. So she gets an opinion from a surgeon, which is that Miss X is not a surgical candidate on account of only moderate aortic stenosis, mental health issues, and a severe tremor in her right hand. The opinion of the TAVI team is that she's got severe restenosis of her valve with symptoms and that treatment is indicated and that she'd be anatomically suitable for TAVI. So the feeling was that this was structural valve deterioration. So she has TAVI workup, so she has coronary angiogram, which was unchanged from 2014 pre-AVR, showing mild atheroma only. She has a TAVI CT, which shows that she's got a heavily calcified valve with suitable anatomy. So the provisional plan is for TAVI. However, there's a bit of concern about how frail she was. She's now housebound, so she's waiting a frailty assessment, which unfortunately she DNA'd. So that's still outstanding. Repeat echo was largely unchanged. So the current plan is for a TAVI, but there is, as I say, some concern about the frailty aspect. So the TAVI is still awaited. So that was just a run through of a case of structural valve degeneration. I don't know if anyone's got any comments or questions about that case.
I think that's great, Nick. I mean, I think it's 9 o'clock now, so I think no, I think this valve was implanted in 2014, wasn't it?
Yeah.
Is that right? Yeah, 2000 TNK, it's 2014. So this is like 10 years down the line. So I think we showed some good cases. I gave you a little bit of background, sort of knowledge about the different prosthetic valves, just to make you maybe think about the different valves. I told you a bit about how the valves are made and why certain valves might be, have a less beneficial hemodynamic effect than others. I showed to you explained the concept of the prosthesis-patient mismatch. And we went briefly around the echo assessment, but didn't really have time to delve into that completely. But we did discuss the sort of the 4 common scenarios that occur and maybe how you can tease them out and how important the baseline echo is to compare it with, and that every report has to refer to the baseline echo. And ideally, you should know, you should know the valve and maybe what the expected reference hemodynamics are. And we also then discussed the cases of so thrombosis, both in the tissue valve and also on the mechanical valve, which is always a scary time and scary moment, and interesting response to thrombolysis in a tissue valve, which was a first for me. And I must say, I predicted that wouldn't work because I thought there was some degeneration as well, and they already were on anticoagulation. But we discussed that, and we showed 2 cases. Other cases, more sort of bread and butter, a PPM case, which was clear because the baseline echo already showed high gradients. And then we showed a tissue, we showed a valve degeneration case. So we had another case, but it's 9 o'clock, or past 9 o'clock, and so hopefully people enjoyed it. And as I said, any feedback of what you want to hear more of, if you want to hear more cases, let's sort of PowerPoint at the beginning, we can do that. I mean, hour and a half, and I really appreciate that actually most people stayed on till 9 o'clock. I must say, I think you're all mad actually that you do that. So it's we really appreciate, and hopefully, as I said, give us feedback. Next one will be in February, and we will circulate the date. It will probably, I think we will talk about aortic stenosis. I think that's such a common thing, and the different types of aortic stenosis, and then some cases. Any comments? Any final comments, Amrit or Nick?
No, absolutely. And I think if people have any suggestions for future sessions, do let us know. And
thank you all for thank you also for Amrit and Nick for doing these cases. Sort of it was often a last minute job. Thank you for Charlie for contribution, and Islam also to helping with things. So it was truly a team effort. Thank you very much.
Just to say as well that we recorded the session, and we'll also distribute the slides to people as well.
Yeah, I sent I just forwarded the PDF file of mine. Yeah. Okay. Bye now. Have a good day. Well,
thank you, everyone. Bye.
Bye now.
Thank you. Thank you.